the presentation.
I can't see it. But can you see me my slides now or not?
Yes, I can see the slides.
Okay, let's try the projection beginning. So is this good? Is this working or not?
Yes, working.
Okay, I will
But you,
just try to tell me.
could you present it in the full screen?
Uh,
No, if you could go back. Not here. And I can see all the slides. Yes. And the down, right? Yes, this one. Yes, this one. Up, up. No, up a little bit. Uh, PowerPoint. No, no, in PowerPoint. Next to zoom in, zoom out.
Yeah.
No. Did you see the positive and minus?
No, I
Positive
can't see. No.
plus and minus for zooming. Yeah. Next to it, there is an icon. No, no, no.
Yeah.
There's another icon in the left.
This one. Yeah, but this is it.
Yes.
This is this.
Okay, خلاص, we can continue.
But it's not full screen, huh?
No, it's
Okay,
not.
let's do again sharing. Okay, awesome. Stop share. Okay. So this is sharing, and I have to pick this screen one, huh?
You have
Is
to.
that correct? Pick this screen one, which is in the blue.
Yes,
Which is in blue.
yes,
Huh?
when you click on share screen,
Okay.
choose only the presentation. Yes.
Okay.
And then present.
Ja, neće se želiti. Počelo bi do 6 realno, pa neće čekati do 6. Mi smo sad odglasili. No share, okay. Let's go here. Jedno na Matjaz Bunc. What should I do?
We can continue at
Okay,
the same
I
thing.
put sharing this. Okay, you are you are in practice session. Okay, then I put this. Okay,
Okay, then present, like the one we did before. I think there's okay.
but I don't know because usually when I put this, the presentation come in front like this. Okay, if I put like this, and now and I will start now. Okay. Okay, now I will go with so with my, this is what I the best what I can get.
We can continue like this. Yeah, it's
Okay, but I have to go at the beginning upstairs. This is not the correct presentation.
yes, I want this.
I have to close this. The correct presentation is I close it. This is intention. Let me find it. So this is the presentation for today. Okay. How we put this to start? Okay.
Okay. I'm gonna mute myself, so
Okay. So the sound is good as it is? Is that good?
yes, it's good.
Okay, let's start. Start.
Yes.
Dear colleagues, ladies and gentlemen, it's a great pleasure and privilege for me to present you today this introduction to your webinar or congress, which is orientated in TAVI and especially in the new device which is performing very well. This is MyVal. So I'm Matjaz Bunc. I cannot move down. I'm Matjaz Bunc from Medical Center Ljubljana. We started with TAVIS in 2009, and after that we have implanted more than 1,800 valves, and this is practically also my personal volume. This lecture is sponsored by Mariel. We started with Edwards valve implantations 10 years ago. In that time, the technology was far less convenient and user-friendly as are the devices today. This is the portfolio of the valves we use in our center, and we are trying to add the devices according to the clinical needs of the patients. But today's star is MyValve. You know the composition very well. The valve is balloon expandable with good geometry and clinical performance, and I will going to talk about that today. The first implantations for CE mark and international were performed in 2018. In our center, we started with the implementation of MyValve in 2019. Today, first of all, we have to pick the proper patients for the technology, and target population is quite moving target, or there are many targets nowadays. They are elderly population, then the patient with comorbidities, patients with previous surgical operations on the heart, and there are also some other subpopulation of the patients that may be targets for the treatment. So we know very well that the age is not a good discriminator for the picking of the patients, and the clinical guidance and clinical practice are sticking to that so much and more. So today is the trend to treat the patients percutaneously or in combination surgical, biological valves and TAVI a long life. So therefore, we have to bring in our mind more and more that this treatment strategy works also in the other clinical items, like for instance coronary approach, durability, to then also good hemodynamic performance. That means that patient prosthesis mismatch should not be the case. We should reduce the implantation rate of the pacemakers, and the coronary approach is a very important issue, especially when we are moving to a younger population. So Mariel tried to stick with these clinical needs with plenty of clinical programs and randomized trials, and they're trying to give us the answer also for some of the demanding clinical situations like bicuspid valve treatment, valve treatment that was already mentioned, the patients with pure aortic regurgitation, non-calcified aortic regurgitation, extreme big annuli, and also, as I mentioned, to low-risk population. So we have to jump back in the history. The first publications about MyVal were presented in Eurointervention, and in that time we were quite skeptic because of really excellent clinical performance and results of the valve. Later, since the population was adapted to the clinical needs, the numbers are not the same, but are pretty the same, and the valve performance is really good, also compared to the other already used valves on the market. What is important for the implanter is that the valve visibility is good, flexibility, stability, possibility to repositioning, retraction from the body, and also the technical performance. About the durability, there is some lack of the data. But what is important, what is positive, we have intermediate and big sizes. Intermediate means the sizes between the classical sizes of the valves that are on the market. That means 24.5, 21.5, and 27.5, and extreme sizes of the valves, 32. So we may cover almost all the anatomical needs for our patient population. So this is how valve looks during implantation. You can see clearly the markers and the suggestion how to implant the valve. If you follow the recommendations from the company, the valve may sit on the place where we would like to put it. We may also manipulate the height with just introduction or pulling out of the valve, and usually the position of the valve is very well predictable. So this is just one case of the intermediate semi-calcified aortic stenosis, especially on the non-coronary leaflet. And you can appreciate here how the dilatation was successful. So we implant the valve. There is actually no aortic regurgitation. The position of the valve is good and the coronary flow preserved. So this is how we may manage the flexibility of the distal tip of the valve. We may adapt them very well to the anatomy of the aortic arch and get better alignment of the valve to the natural anatomy. So even in this demanding situation, you can see here quite horizontal, very tortuous aortic arch and the position of the aortic valve. And even in this situation, the implantation of the valve might be fluent, very predictable, and you can see here there is no aortic regurgitation. So even when we approach through the peripheral arteries, you can see here, even in severe tortuosity, the valve delivery system is very flexible. So you can see here the successful positioning of the valve. In this particular case of valve implantation, we implanted MyVal 26 in Evolute 29. But one of the possible contraindications might be severe tortuosity, which was overtaken here. So this is also very important fact about the valve. You have these intermediate sizes, which are very frequently used in the clinical practice. So if you follow the usual flow work of the high volume centers, you can find out half middle size and half normal size, if I may call that, valves. But these very big sizes are used very rare. But in case you don't have then you cannot use it even in very demanding situation. So this is another interesting case with a patient with aortic stenosis. Here are the measurements, and we follow the measurements to the sizing chart. You can find out here that the 27.5 valve should fit to this patient. Our goal is to do the oversizing according to the CT measurements up to 20%. So here, so this is also part of the valve selection, and here is how the implantation works this patient. So you can see here also very nice and good position of the valve and excellent result without any aortic regurgitation. So there is also another question: what about the valve durability? So we cannot talk about the valve durability more than 5 years in case the valve is just five years in the clinical practice. But every year we are gaining the clinical experiences and data about the durability. This is the first case of MyVal that was performed in clinical center Ljubljana. You can see here the patient where the valve was implanted smooth in a good position without aortic regurgitation. And you can see here also the echo data in the follow-up 3 years after the implantation. All the parameters are stable. There was no valve dysfunction. There are plenty of clinical studies or data which have already proved good clinical performance of the valve. I will not go into details, but here is just the list of different studies and registry analyses. We have 3 randomized trials. This is landmark trial, then compare trial, and also the matchball trial. But the rest of the trials are registry analyses, which are driven by the company and by researchers. and give us the studies gave us already good impression how should the valve perform in certain clinical situations. So we stick that just to randomized trials which are just running. One is the landmark trial, where is the comparison between the three valves. Evoluts are the Edwards valve and the MyValve. This is 112 manner. And there will be acute data, I think, presented in the next EuroPCR about the 30 days performance of the valve. And we will also all the centers that are involved in the study. We will follow the patients for the next 10 years to obtain all the clinical data about durability and clinical performance later after implantation. Another study is investigator-initiated study. This is the study compare. They have two arms. In one arm, they compare accurate Neo versus Sapien, and the second arm, MyValve versus Sapien. The basic idea is also to follow the clinical performance of the valve and the maze after a certain period. In the certain period after implantation, the follow-up should be also up to 10 years. And this is the third trial where they compare the clinical performance of Evolut, the Edwards and MyValve. I will not go into details; they're available. But what was shown here at this stage of the clinical use of the valve, that there is no difference in the clinical performance regarding to the aortic regurgitation and functional area after implantation of the MyValve and Edwards valve. But at least according to this analysis, the implantation rate of permanent pacemaker was lower in MyValve. What is probably not really in everyday clinical practice. It's quite comparable for the both valves. So this is another case of intermediate valve implantation. Also performed in clinical center of Ljubljana. Again, you can see a little bit horizontal position of the aorta with the angulation and proper positioning of the valve. The final result is excellent valve one, and the coronary flow was preserved. There is also a comparison between MyValve and Edwards, also between the Evolut and MyValve. In this registry analysis, they try to find out, first of all, clinical performance of the valve, which was according to the VARC 3 criteria better in favor of MyValve. There was even also less as a part of this analysis of aortic regurgitation, and you can see all the followed criteria or clinical events were in favor of MyVal, except the stroke rate, which was quite comparable. So what is important for the MyVal in this stage is that it's non-inferior to the comparators like Edwards and Evolut. Okay, here is another case. This is the implantation of the MyValve in the bicuspid valve. This was the first actually proctored case in Dedinje in Belgrade Hospital in 2029. You can see here also, although we have demanding anatomy, and this was the first implantation for the center. The primary result was the excellent one. In bicuspid aortic valve, there was no aortic regurgitation, and the performance of valve as well of the patient was good. So this the clinical outcome and the function of the MyValve comparing to Evolut and Edwards was also tested in this Triton study, where they tried to compare what is the hemodynamic effect and artificial area after implantation of these three devices. And you can appreciate here that at least according to the mean gradients of the implanted valve into bicuspid valve and artificial area, MyValve is at least comparable to the both competitors. So I would like to stress again that there are also plenty of the other fields where the MyValve is tested, even in low-risk population, in our pure aortic regurgitation. We just did one case today here in Sarajevo, but you should take care about the sizing of the valve. So we have to wait for strong clinical data. This would be obtained from both randomized trials. One is landmark trial where University Medical Center of Ljubljana is one of the most important introducer of the patients. So today we are thinking about the long-term strategy of treatment. I will show you now just a few interesting cases more. So after surgery, we usually try to do the biological valve degeneration treatment with TAVI valve-in-valve implantation. And here are just some of the possibilities that were already published in one of the articles. They just collected the implantation of TAVI devices, MyVal in the different biological valves. So we have quite a lot of experiences in Clinical Center Ljubljana with implantation of TAVI devices in different biological valves like Enable, Perceval, Solo Freedom, and plenty of other valves. The collection is more than 110. So this is just one of them. This is implantation of Medtronic degenerated Enable valve with severe calcifications. And you can see here that the final result of the implantation was not the best one because enable was small, and you can see even after implantation of the valve, the patient prosthesis mismatch was the case, and the speed on the valve was quite high even after implantation of the valve. This is another case of implantation of MyVal into Perceval valve. Perceval valve is also sutureless biological surgical valve. And after implantation of the MyValve into Perceval valve, the clinical performance of the patient as well as the echo parameters were much better. You can see here the reduction of the speed from 3.8 to 2.2. Surface area rose from 0.6 to 1.3, and the patient's performance was much better. You can see here also good result without any regurgitation. Cannot move on. There's no problem. I would like to share also some other interesting cases with you, but okay. This is another interesting case. This is the lady I showed the peripheral approach earlier. She was treated with biodental operation in 1998, and after 15 years, in 2016, there was degeneration of bicuspid valve because this was not by Benton, but Tyron David, and bicuspid valve degenerated 18 years later. So the decision in that time was to implant TAVI device into degenerated bicuspid valve. You can see here what was the anatomy, because the basic reason for the treatment in 1996 was the dissection of ascending aorta. You can see here true and false lumen. True lumen is marked with here. And we successfully implanted evolute valve into this degenerated bicuspid valve. But after a certain period, the patient presented in our institution because of severe aortic regurgitation, which was the reason for the treatment. The reason for regurgitation was degeneration of one of the leaflets, and there was also some PV leak. So this is how the valve sits into aortic anatomy. It's a little bit lower. This was our intention. We implant valve a little bit lower to secure the good anchoring. And this was good strategy for 5 years. But after that, the combination of degeneration, as I told, and PV leak make us to do another step in the treatment. And we decided to implant MyVal 26 into Evolute 29 valve. We targeted the natural annulus, 0.0 in bicuspid anatomy, actually. And the final result you can see was good without any aortic regurgitation. And the hemodynamic was also improved. You can see here that although the ejection fraction stayed the same, the patient performance was much better, and the echo parameters also improved. And now the last case, nowadays we are facing the strategy of the multivalvular treatment. We have quite experiences with the combination of aortic mitral valve, mitral tricuspid treatment, but there are also some patients with, for instance, aortic stenosis, mitral stenosis, and tricuspid regurgitation. What is logical consequences in case we have multivalvular disease? Let me share with you one interesting case. This is the 71 years old lady present in 2023 because of ascites in our clinics, but her history was that she was treated in 2022 because of aortic stenosis with implantation of Evolut R device. After that, because of this readmissions, because of ascites, we decided to treat also mitral stenosis. So this is how we implant the Evolut valve. This was successful and hemodynamics improved in that lady, but this is the situation, how it looks. This severe calcified mitral valve, this severe stenosis. So we decided to do transeptal TAVI in MEC with Evolut, with MyVal 26 millimeters. So this is the strategy. This is transeptal puncture and introduction of two supportive wire, dilatation of the septum, then introduction of the device transeptally with the body wire support. Then we remove the wire and position the valve at side. So what is very important in the positioning, you have to have a very good 3D echo. You can see here the positioning was done by the echo strategy from clips. You can see here that one side of the valve is facing the atrium, the rest into the ventricle. And by using the echo, we positioned valve very well. So this is then the position after implantation. We have here aortic valve, here in mitral position, MyVal. The gradient from the ventricle to the aorta was 0, and you will see here there were acute improvements of the hemodynamics on the mitral valve and pulmonary pressure. You can see the reduction on both sides. And here is the final, in acute phase after implantation of the TAVI in MEC, there was a substantial reduction of the tricuspid regurgitation. So the lady is now without ascites. We are just waiting a few more months to decide whether to do the clipping of the tricuspid valve or just stay on the optimal medical treatment. And this is the final analysis. You can see here improvement, important improvement of the hemodynamics on the valve, and you can see also here morphologically much changes in the mitral valve, and you can see here quite good ovality of the implanted TAVI device. So let me conclude. We know nowadays that MyValve has good clinical characteristics. There is lack of some data, especially about the durability. But we have good acute data, and we have plenty of the indication that are proving in everyday practice and in registry analysis, and probably also in the randomized trials. So what should be the most important advantage of the valve? This intermediate sizes, good flexibility, and extreme sizes, which may cover the clinical needs that the other valves cannot provide. Thanks for invitation, and wish you a good meeting.